All right, so gastric disorders. So we move it on from esophageal CA to peptic ulcer disease and gastric cancer. All right, so peptic ulcer disease is an ulceration of the stomach lining, and they thought it was due to an imbalance of pepsin and acids. And so what they said is, hey, you have too much acid in your stomach, take some pepsin. It's like that. How's that going to help, right? So we're going to help digest more. So so back in the day, you had pepsin gum, and Pepsi Cola had pepsin in it to help you digest better. They thought that was a thing. It was what do they call it? It cures indigestion and constipation, right? So Pepsi Cola used to be a medicine that they swore up and down by. That was before the FDA. Anyways, we're talking about gastric ulcers. We talked about GERD already. We'll talk about gastric carcinoma, and we're not talking about these ones. Or maybe a little bit about atrophic, just a little bit here. Okay, that kind of relates to gastric cancer. All right, so overview of PUDs, peptic ulcer disease. So PUD is an umbrella term, and it is under that umbrella you have, that's supposed to be an umbrella, you have a duodenal ulcer and a gastric ulcer. So either the ulcer geographically could be after the pylorus or before the pylorus, right? So it can be right here, and that's what we call gastric or duodenal, if that is right when we're talking about. Purple circle.
That's duodenal.
It is gastrum, right? So the pylorus is right here, right? And if it's in the duodenum, it'd be a duodenal ulcer. And gastrum, gastric ulcer, just geographically, right? So basically you're eating through the lining of the stomach, right? You have protective layers out there. You have a protective layer of mucus and bicarb that protects your stomach lining from getting eaten away by the acid that's in your stomach. So that lining could go away. We can reduce the amount of bicarb production. We can reduce the mucus production. And not on purpose, but because of the different causes of peptic ulcer disease. Okay, it was thought to be due to stress and anxiety, but that's not true. If you're like stressed like in the ICU, yes, and it's not really because of the stress. It's because of the hypotension, like we described before. You have low blood pressure, and it can't take away the acid that's all building up inside the stomach here. So you have all this acid building up, and it's waiting to get reabsorbed into the bloodstream. But you're hypotensive. You don't have a lot of good flow and washing away of the acid. So everybody in the ICU is usually on pantoprazole for that reason, to reduce the acid production. All right. So also in the 80s, everybody thought it was pepsin and acid imbalance. So they tried, increasing pepsin or decreasing acid, but come to find out it was a bacteria the whole time, right? And nobody believed the guy that was saying it's bacteria, I swear. So he just said, look, and he just downed it. He just drank it, right? And he got peptic ulcer disease. And he says, see, and he won a Nobel Prize for it. There's not many things you can win a Nobel Prize for swallowing bacteria, right? Anyways, that's how they discovered that it was H. pylori was the bacteria, right? The gram-negative bacteria that when it gets attached to the stomach lining, it's going to start making the environment like its own, like it likes. It can survive in acidic environments, but it creates an alkaline environment so that more of H. pylori can procreate. Right? So here's our H. pylori right here. It's going to start proliferating exponentially and making the environment more alkaline for its friends. Okay. All right. So peptic ulcer disease is super common, right? And there's some pro-inflammatory states that make you more at risk for peptic ulcer disease. You're diabetic, COPD, CKD, obese. These things put you at higher risk for peptic ulcer disease. And there's about 15,000 people die per year because of these complications. So this is much more serious than than GERD, for instance, as far as causing damage to the stomach lining. Okay, so alcohol, smoking, alcohol is directly toxic to the lining. NSAIDs, we said aspirin was, KCl. These things are all directly toxic to the lining. And it's going to eat away and eat away at the lining until it eats away to what? This blood vessel that's down there. And now the blood vessel is going to start bleeding and bleeding and bleeding. And now you have a GI bleed, right? And not only can you have a GI bleed, you can eat away and perforate, right? Is that good? No, that's going to cause what symptom? It's going to inflame the what? The peritoneum, right? The peritoneum wraps the stomach, right? And that peritoneum is going to get ouchy, right? So they're going to have a rigid board-like abdomen, and they can have peritonitis as a worst-case scenario. And they're both bad if you have a GI bleed and peritonitis. Okay, so it can eat away, eat away, eat away until it can actually perforate through the GI tract, whether it be the duodenum or the gastrum. Right? You might see on the chart they'll say perforated viscus. Like, what's a viscus? A viscus is a GI organ, a GI tube. Right? So either the stomach has been perforated, the duodenum has been perforated, and you can perforate other things too. When we talk about diverticulitis can perforate the sigmoid colon. All right? Appendix can rupture. Right? So whoopee, zoom your troubles away with a glass of Pepsi Cola. All right. So again, we have the gastrum and duodenum. The duodenum is much more popular than gastrum. All right, gastric acid is corrosive, and if we eat away at the lining and we don't have this mucus layer to protect ourselves, then we're going to get more and more ulceration over time. Right? So we can damage mucosa in a few ways. Right? It's just more acid production. And how do you make more acid production? Well, alcohol directly increases acid production. Gastrin is our normal hormone that gets released when there's protein in the stomach. Protein stimulates gastrin, and gastrin will stimulate hydrochloric acid production and digest the protein, right? But alcohol will also just digest the stomach lining too, all right? There's a rare tumor called Zollinger-Ellison, which will just produces too much gastrin, right? But H. pylori will stimulate acid production. We said E2H does, and NSAIDs will increase acid production, as we'll show on the next slide, I believe, all right? You got an impaired mucus layer, so we're not producing bicarb, we're not producing the mucus that's protecting the stomach here. So remember what's protective in the stomach? What chemical is protective? It's prostaglandins, right? And prostaglandins are protective, and they actually inhibit hydrochloric acid production and stimulate bicarb and mucus production, right? So if you take those away, then you're going to have less mucus and bicarb and more acid. And how do you take away a prostaglandin? Steroids and NSAIDs. Steroids and NSAIDs directly inhibit. So here's NSAIDs. Here's my prostaglandins right here, right? So NSAIDs are COX blockers, excuse me. All right, so they are going to block COX enzyme, cyclooxygenase, and they're going to stop the production of prostaglandins. And steroids also stop the production of arachidonic acid. So steroids and NSAIDs are going to stop bicarb mucus production and also increase hydrochloric acid production. So you can see it's like a balance, right? Just like you have increased damaging things, and you have decreased protective things. Okay, and lastly, decreased blood flow. This is kind of the ICU thing. Yeah, someone's hypoxic flow to their cells, the cells are going to start to die, and when cells die, they're more vulnerable to damage. Okay, and the repair of the damage is imperfect. It's usually scarred. It's not scared scarred, but it's a scar tissue develops. And if you have diabetes, COPD, obesity, are you going to repair well? No. So that's going to put you at a higher risk for ulceration and lack of repairing function, right? And then cigarettes impair ulcer healing. We know this from first semester with wound healing in general, right? Someone's malnourished, obviously going to be at more higher risk. Okay. So all these things are going to lead to our symptoms of peptic ulcer disease. Okay. Before we get there, we got H. pylori and NSAIDs. So we talked about NSAIDs already, that prostaglandins are protective, and they are going to help the stomach. They're going to help increase blood flow to the stomach. They're going to decrease gastric acid production. You can see here that there are prostaglandins. They inhibit the parietal cells. Therefore, you have less hydrochloric acid. Sometimes we can give the building blocks of prostaglandins with what's called misoprostol. So misoprostol is a synthetic prostaglandin we can give patients that have ulcers due to a lack of prostaglandins. And who has lack of prostaglandins? Patients on NSAID therapy. Right? So NSAIDs, aspirin, ibuprofen, naproxen, and ketorolac, in that order, are toxic directly to the stomach, but also they inhibit the prostaglandin production and therefore cause more acid. So here again, we got corticosteroids and NSAIDs. They are blocking the beneficial prostaglandins. Okay? And then H. pylori. So H. pylori, we kind of touched on. H. pylori makes its way in, right? If you want to win a Nobel Prize, you just swallow some H. pylori. It's going to get in there, right? H. pylori is going to proliferate, right? It's going to proliferate and proliferate and proliferate, and it's going to convert urea to nitrates, to ammonia. And ammonia is basic, so it's going to make it more basic inside the stomach, right? Makes the pH rise. And if the pH rises, it makes it much easier for more H. pylori to proliferate. And H. pylori, they're going to make their way down to the tissue level, and they're going to become irritating. They're going to burrow down and cause an inflammatory response. And then we are going to attack the H. pylori and cause more inflammation. And now when you have an inflammatory response, you have steroid, you have glucocorticoids circulating, you have all kinds of, and people are going to take ibuprofen because it hurts, right? And ibuprofen is going to be a downward spiral, and we're going to have peptic ulceration, right? So how do you get H. pylori? It's transmitted by not washing your hands. Something as a simple teaching: wash your hands, right? So you don't get H. pylori, right? You have water treatment. You're in the city of Detroit, right? You're going to, or Flint, Michigan. You're going to get you get H. pylori. Okay, contaminated food, right? You go to, what was it recently, Panda Express, right? You get hepatitis A, you get some H. pylori also. Okay, so those things are ways you can catch H. pylori. Okay, so that's important teaching you would do. All right, what else on here? This is just showing you how NSAIDs and steroids interact with this. Okay, and just as an exception, Tylenol is not an NSAID. It's like a quasi-NSAID. It's a wannabe NSAID, right? It doesn't actually do all the anti-inflammatory actions. It works primarily in the CNS. It does inhibit some prostaglandins, but the ones in the CNS specifically. It's not antiplatelet. It's not gonna, it's just works like on headaches and fever control. All right, so diagnostic tests and symptoms. So this table up here summarizes it, what the difference is between a duodenal ulcer and a peptic ulcer. That's only like in 30% of patients. It's like, that's less statistically significant than a Homan sign, right? So it is not 100% that you have pain 2 to 4 hours after you eat, dang, you have a duodenal ulcer. They could have a peptic ulcer, right? What's more important is that they have epigastric pain. It's going to be a burning sensation in the epigastrium. Why the epigastrium? Because what's right behind the epigastric space on our abdominal assessment is our stomach, right? It could be our stomach or our duodenum. Okay, so it's subxiphoid. It may radiate a little bit. All right, it's a burning sensation, not a pressure. If it's pressure, what does that usually tell you it is? It might be cardiac chest pain. We're going to get an EKG anyways, just to make sure it's peptic ulcer disease and not an MI. Because can patients with peptic ulcer disease get MIs? Yeah. All right. So periodicity. I don't know what I'm saying. Anyways, it comes, it goes. All right. So it happens, for weeks or months at a time, then it goes away. If it's persistent and I'm on medications for it and it's still bad, that means what? That's an alarm symptom for what? Cancer. For cancer, esophageal or gastric cancer for that matter. Okay. They got bloating and belching, right? That H. pylori is going to start creating gas, right? Gas production is a feature of bacteria, right? We have bacteria in our stomach. Sometimes it gets neutralized by acid, but where else do we have bacteria in our gut? Where else? So it's not in the small intestine. The small intestine is sterile. Large intestine, right? The large intestine has bacteria, and everybody has a different kind of bacteria, right? You can't get two people to have the same bacteria, the same milieu of bacteria, right? So the gas is formed by bacteria. So really our farts are secondhand, right? They're not even our farts that we made. It's the bacteria in our gut. And everyone's fart is unique. So you can smell someone else's fart and say, oh, look, Mike's here, right? I'm going to go over here now. All right. So yeah, so these are, you can get belching because of, if it's due to H. pylori. Okay. So duodenal versus peptic ulcers, just see the table over here is classically, if you're eating right away, you get like a protein meal, you're going to start releasing gastrin naturally, and you're going to get that acid going to get secreted, and that's going to hurt. So if you have like immediate pain right away, that might be what kind of ulcer with eating? Might be a gastric ulcer, right? Peptic ulcer is a correct answer because peptic ulcer is the umbrella term, right? But specifically is it gastric or duodenal, right? So what else? Is it improved with foods? A little bit, because you're going to stop secreting foods secreting acid into your duodenum, and you're going to start secreting acid. You're going to start digesting what you have right there. So duodenal can be saying they can improve a little bit. Okay. What else? Likely to be cancer. So gastric ulcers, that's prolonged exposure to acid and prolonged ulceration and prolonged damage. So gastric ulcers are more prone to cancer. Is there such thing as duodenal cancer? Yes, but which one gets exposed the most? The gastric is there for 2 to 4 hours guaranteed, right? And the duodenal ulcer is just passing through, right? Has another 20 to 30 feet of small intestine to reach. Okay, and diagnostic tests. So again, EGD. So EGD is there. It can go in there. It can then take a little sample of the tissue, see if it's cancerous. It can take a sample of the tissue and see if there's H. pylori present. They can do a culture of the stomach contents to see if H. pylori is growing. And what does H. pylori like to make? It likes to make ammonia, right? So we can put it into a little test tube and say, hey, make ammonia. If it does, that ammonia is going to be made, and it's going to make down. It's actually going to break down urea as well, and it's called a urea test, right? There's also something called a urea breath test, where you test the breath, but this is a little more refined, right? You can also do antibodies. We form antibodies against everything, every foreign thing in our body. So we also form antibodies against H. pylori. H. pylori is foreign. So we form antibodies, and you can do a blood test to see if those antibodies are there. That's more expensive than a stool test. So you can just do a stool antigen test. You can say, send me your poop, and I'm going to test it. And if it has antigens against H. pylori, congratulations, you have H. pylori, right? Especially if you have these symptoms at the doctor's office. All right, any questions on symptoms of H. pylori and diagnostic tests? We can do a biopsy, we can do antibodies or stool antibodies, or a urease breath test is another option. All right, so let's take a quick break and we'll come back for the pharmacological treatment for PUD. I'm back at 35.
I'll try to set this up right.
All right, so finishing up PUD. So PUD, peptic ulcer disease, what are the two types of PUDs? Gastric or duodenal. And you can differentiate them, but that's only like 30-40% of the time. For the most part, they are going to have generalized symptoms. It's going to hurt, right, when you're eating through your own lining. And the H. pylori is in there doing what I didn't record, right? Where are we at here? Right? So it's making it more, well, I'm writing on the screen here. Okay, I'm alert ANO times 2 right now. All right, so we have a H. pylori is going to make it more alkaline, right? It's literally converting things into ammonia, right? And ammonia is in urine, right? So and then also those pills can damage the stomach lining. So if someone has H. pylori and they're taking NSAIDs because they have like chronic pain, that's going to be a problem, right? All right, so yeah, so NSAIDs, usually we'll do a little holiday with NSAIDs if they do need NSAIDs, and we may even provide more prostaglandins because NSAIDs block prostaglandins, right? So we may give a synthetic prostaglandin, that's misoprostol right there, right? So NSAID users hold NSAIDs for 8 weeks, and then maybe when they resume it, once the ulceration goes away, we can start a pantoprazole or a proton pump inhibitor along with it, right? And then acid suppression, so same thing, antacids, antacids, and our friends H2RAs and PPIs will be there to hope that will alleviate pain because it's going to stop the underlying problem. But we still got to get rid of H. pylori, right? Those are not antibiotics. Pantoprazole does not kill H. pylori. It actually potentiates H. pylori. Pantoprazole lays the groundwork for more bacteria to proliferate, such as H. pylori and what else? C. diff, right? So you can get C. diff and you get H. pylori and other complications with pantoprazole or PPI therapy, right? We're still going to be on a PPI to reduce the amount of acid that's going to cause breakdown. But we're also going to hit them up with some antibiotics to take care of that H. pylori, if they have H. pylori. How do you know they have H. pylori? We did a urea test, or what else? You can do a antigen test, whether it be stool or blood if you're more cultured, right? So we have what's called triple therapy or quadruple therapy. Triple therapy, both of them hit them up with pantoprazole. But the other ones are going to hit them up with 2 antibiotics to really get rid of this gram-negative bacteria, right? And they'll do repeat testing to make sure that the H. pylori is all gone, okay? Also, one of these, like quadruple therapy, it adds bismuth. Bismuth is your Pepto-Bismol, right? That's how it got its name, all right? So bismuth is going to neutralize, or it's going to coat the stomach lining, and it's also bacteriostatic. It like catches the H. pylori, and it looks like like a slime, right? So here's our misoprostol providing that extra bit of prostaglandins, right? We have our What else? Famotidine is a what? It's a H2 antagonist or agonist? Antagonist, stopping H2 from making hydrochloric acid, right? Also, we have pantoprazole or PPIs, right? PPIs. Those are working directly at that parietal cell, right? And then H. pylori, we can take care of them with triple or quadruple therapy. We got bismuth, which is going to kind of trap the H. pylori, and sucralfate is a nice medication. Sucralfate is a medication that will coat the lining of the stomach, kind of like bismuth does, but also it's going to bind to the ulcer, and it's going to create a nice protective layer. So it's twofold. It's like it lines the stomach, but it also specifically lines those ulcers. It kind of targets them. All right, so complications of PUD. So we can have a GI bleed, right? It can be a significant GI bleed because you are breaking through. See the ulceration right here? It's ulcerating, 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 and it's going to ulcerate through a blood vessel, and that's going to start bleeding profusely, right? So it'll be an upper GI bleed. It could also be bright red blood per rectum if it's a significant bleed. If it's a slow bleed, it'd be what? What per rectum would you find? If it's a slow bleed in the stomach. Be dark, it'd be a melena, right? So if someone has hematemesis or someone has hematochezia, we need to get an EGD done. So EGD is going to look for that bleed, and they can then fix it right there on the spot with EGD. The EGD is going to look at it and say, oh, look, you have an ulceration. But also, they're going to, with EGD, they can fix the problem. They're going to go in there and they're going to put what is called a clip, right? They put a little clip, it's like like binder clip. It goes in there and it just cinches the vessel, right? And it stops the vessel from bleeding. Okay, and then if it doesn't cause a GI bleed, it can ulcerate further and further and further until it does what? Until it perforates. I thought I saw perforation there. There's a perforation. All right, in the top right. So it's going to perforate, and it's going to, now you're spilling GI contents, including H. pylori, which is still a bacteria, and you're spilling that into the abdominal space, right? And there's air in the stomach, so the air in the stomach is going to leave and go into the peritoneum. You should not have air in your peritoneum. And you can actually see it on X-ray. If you see it, there's the diaphragm there. Air is black on X-ray. You can see a little bit of air underneath the diaphragm there. That's a sign that you have free air under the diaphragm. And that usually means you have a perforation somewhere. Not good. So chest X-ray can help you find it. A CT will let you find it as well. We can do an abdominal X-ray to see if there's free air there as well. But that perforation, they perforate the bacteria there. Is it there for long enough? 1 to 2 hours, it's going to start causing peritoneal symptoms. And peritoneal symptoms we've discussed, but what kind of symptoms are they going to get? They have peritonitis. They have diffuse, rigid, board-like abdomen. They're going to distension over time, and it's very, very painful. Okay, diffuse abdominal pain. All right, and they need emergent EGD for a bleed. They need emergent surgery for peritonitis. Sometimes the bleed is so bad they can't fix it with an endoscope, and they still need to go to surgery to take out a piece of the stomach that's bleeding or is perforated. All right, so also you can get obstructions because it can cause scarring, gastric adenocarcinoma. That sounds like cancer, right? So just like GERD led to what kind of cancer? Barrett's, which is precancerous, and then esophageal CA. PUD can lead to gastric CA, especially if it's H. pylori. H. pylori independently, because it's in there and it's causing inflammation inside the lining, right? All right, what else? So interventions. So EGD is our first thing that we're going to do. And then surgery is usually only required if EGD can't do the job, right? And examples of surgery, they can put a patch over it, they can sew it together. They can do a distal gastrectomy, they can take out the portion that's not working. They can open up the pylorus if they had scarring there. All right, they can do a vagotomy. What's a vagotomy? That's where you can't have kids anymore, right? What's a vagotomy? You're cutting the vagus nerve, right? Not the vagus nerve to the heart, but the vagus nerve goes everywhere throughout the GI tract, right? So the vagus nerve gets cut to the stomach. And remember, the vagus nerve releases acetylcholine, and acetylcholine acts upon the parietal cell and increases hydrochloric acid. So it's going to help in that fashion, all right? So those are the things we can do if someone's their gastrum or the duodenum perforate. So this is what kind of ulcer right here that's perforated? That's a duodenal because past the pylorus, right? All right, so gastric cancer. So we moved on to cancer now because H. pylori can cause cancer and also repeated ulceration can do it. All right, so you have malignant epithelial tumor, and it's going to infiltrate and grow and grow and grow until it metastasizes. So metastasis is what stage cancer? Stage 4, right? Gastric cancer is the most common cancer worldwide, right? And in America, though, we've outdone it with lung cancer and reproductive cancers and colon cancer because of our diet and such. But anyways, it's still like third, fourth place for most common cancer death. What else? Males are much more at risk, right? The 5-year survival, 23%. And is that good or bad? That means at 5 years, only 23% are still alive, right? So it's really bad. It's discovered late. So it's the same thing like with esophageal cancer. They have to be alert to warning signs or alarm signs, right? What are alarm signs again? So you got GI bleed, right? But what else? The autophagia and dysphagia, that's more for esophageal cancer, not so much for gastric cancer. But yeah, it could still be if it's at the top of the stomach up there. Then that can start compressing, make it difficult to swallow and such. But it's your unintended weight loss. You got the GI bleed, iron deficiency anemia. These are things that what you would consider doing a evaluation of their stomach to see if they have a stomach cancer. All right. What puts you at risk for stomach cancer besides H. pylori? Because H. pylori is a big one. All right. So here's H. pylori down here. 3 to 6x risk of getting cancer. E2H is smoking. That's every cancer. But what else is your intake of high salt foods? So really high salt foods, not like just like Doritos, but high salt foods like you're like on a pirate ship and you're eating like salted salmon and you're eating like pickles every day. Not kombucha, what's the other one? The kimchi, right? So you're really going to town with all the high salt foods. That's going to start drying out your stomach. It's going to start causing a what's called an achlorhydric stomach. So that means without hydrochloric acid, all right? And no hydrochloric acid means the pH is going to go up, and now you have more bacterial inflammation, and now you have H. pylori can take hold, right? Also, there's different foods that produce nitrosamines. So nitrosamines are cancerous. They are carcinogenic. And what that means is there's certain things that have healthy nitrates in it, but when those healthy nitrates hit something that's a protein that's been charred on a barbecue, like 24 hours, like smoke and Cherokee and chicory wood and what's the other one, right? Once it hits that, it makes a nitrosamine. It tastes great, but it's actually cancerous, right? It puts you at risk for gastric cancer, right? So nitrates can be great, like for instance, they're in cabbage and some other cruciferous vegetables and such, and they'll be converted to nitric oxide, which is a vasodilator. It's going to lower your blood pressure. It's great, but as soon as they hit a nitrogenous compound like something that's been smoked or processed meat-wise, then it's going to cause nitrosamines, and nitrosamines are cancerous. All right, specifically, they're highly cancerous or highly associated with gastric cancer. Okay. Yes.
What do you mean, like it hits it, like if you consume it together?
Yeah, it creates a chemical reaction with the burnt foods, or not burnt foods, but like processed meats and smoked meats and such. They interact and they create free radicals. That's what ROS is, reactive oxygen species. So ROS are free radicals, right? It's like, oh, just eat some vitamin E. It's like, it's not going to do it. This is going to create an environment that's going to promote gastric cancer. Okay, so you see up top right, we got H. pylori just taking hold. It's going to raise that pH of the stomach, and it's going to make it achlorhydric. Did I say that right? Yeah, achlorhydric. It's going to make it more and more alkaline. It's going to dry it up, you can think, and it's going to kind of shrivel up. Literally, when they look under the endoscope, it looks shriveled up. It looks like all the rugae have disappeared. Okay, and it's constant inflammation, and inflammation leads to cancer, right? See all this inflammation from the bacteria itself, and then we try to fight the bacteria, and we cause inflammation. And that constant inflammation over time is what causes gastric cancer. So you can see in the bottom right, the meat products and touching our veggies, right? I guess my 9-year-old is correct. She doesn't want anything touching her food, right? So it's going to then start causing a risk factor for gastric cancer. All right, so what's going on? There's 2 types, intestinal and diffuse. Basically, intestinal type, that's the one with H. pylori. That's the one where you have these environmental toxins, everything are over-proliferating, causing a gastritis, our stomach to be inflamed and also atrophic. It's literally atrophying because of all how alkaline it is. And then it undergoes changes, and we've got all this constant inflammation. Constant inflammation causes the atrophic gastritis, and then we eventually get carcinomas out of this. Okay, and then diffuse type is usually the mutations that may happen. I think alcohol and smoking is probably on there. It's probably the right answer for everything. But anyways, we have just like a genetic reason for our cells just to one day decide it's not going to follow the rules and it's going to over-proliferate. Okay, so we have intestinal type on the left here, and we have gastric or diffuse type on the right. That's the diffuse type is where we have our proto-oncogenes, our tumor-suppressing genes that are abnormal, and therefore the tumor just keeps growing and growing and growing, right? Has like a leather-like appearance as well. And on the left there, it's kind of localized, but it can grow and grow and grow, and it can metastasize. Okay, so symptoms, diagnostic tests, so they're in orange at the top middle. So that's your warning signs, your alarm symptoms that you want to teach every patient so they can report to you. Do you get any GI bleeding? Do you have any weight loss? They got any palpable mass? So they can feel something, especially in a thinner individual, but if they can feel a palpable mass, and then gastric cancer can grow big enough to make it difficult to swallow, but usually gastric cancer, we have the early satiety, right? They have a long-lasting PUD symptoms, so their ulcer symptoms don't go away. They've been on quadruple therapy, triple therapy, all the therapies, and they still have peptic ulcer disease symptoms. That's someone that has a high risk for gastric cancer. They should get a what? They should get an endoscopy. They should get an EGD to figure out what's going on. They're going to get a biopsy and see if the cells have changed shape. They could do a barium study, but usually EGD would be better. The barium study will show if there's a mass in there or something. Okay, what else can we do? We can do an X-ray to see if there's metastasis, because gastric cancers like to spread locally, right? They're going to go to where? They go to liver, lung, lymph nodes. They like to go to specific areas, like right here of the subclavian, right here in the belly, right? It's called a Sister Mary Joseph node. I don't know if you like pray with it or what. Anyways, and you got a Virchow's node, just right below the subclavian. It's just unique to gastric cancer. The other thing that's unique for gastric cancer is the CEA antigen. So the CEA antigen is positive, so they can do a blood test. Which cancer did not have a blood test? Esophageal cancer. You can't do a blood test for esophageal cancers. Oh, you might have esophageal cancer. But they do a CEA antigen test, and they say, oh, you might have gastric cancer. Let's get you scheduled for an endoscopy, right? And there's another cancer that's a risk that has CEAs. We'll talk about it. All right. Anyways, treatment. So you can do, again, the progression for all cancers is let's try to scoop it out, right? Let's try to excise it and take it out with maybe an endoscope or something. And then the next step is let's try to radiate it. Let's try to put irradiation to destroy the cells. Next step after that is do chemotherapy, right? And chemotherapy is usually at step 4, right? Which is grade 4 cancers or metastatic cancers. And that's true for every cancer. That's kind of the progression, okay? All right, so radiation, going down, and then we could do surgery. Surgery is usually, we'll try to resect it with our, if we can do surgery early, we can capture it and yank out the cancerous pieces, but hopefully we can grab it all at that point. If we do take out the gastric cancer, we're at risk for what happens when you have a straight shot from your esophagus all the way down to your duodenum or ileum. You're at risk for dumping syndrome. All right, and what are symptoms of dumping syndrome? You got hyperglycemic all of a sudden, and then your insulin's going to kick in and make you hypoglycemic. All right, it's the same thing when you drink soda after eating some ice cream. You feel horrible, right? You just created dumping syndrome. I should serve that next time, soda and ice cream. Anyways, and you'll feel dumping syndrome in real life. Anyways, you have a hematologous spread. You have a metastasis, which will go to the localized organs, and it's a really bad prognosis at that point. It's always a bad deal with gastric cancer because it's discovered late. Not everybody gets routine scans of their belly because A, it's expensive, and B, it's the symptoms are late.